you so much. Uh, this is the third conference of Global Psychiatric Association, and I'm talking about the early augmentation of psychiatric disorder for the second time. In the first Global Psychiatric Conference, I presented the concept of what exactly early augmentation means uh, and discuss about some of the existing evidences about it. But over a period of 2 years, I did some of my research work in this area, and now I can say that there are some more evidences where I can talk about early augmentation and its relevance, scope, and challenges. So this is the institute where I work. This is King George's Medical University, located in Lucknow, Uttar Pradesh, which is a city in the north part of India. We all know that psychiatric in the management of psychiatric disorder, we face a lot of challenges. One of the common challenges is stigma. Because of stigma, people are not uh, eager enough to seek mental health support. So there is a poor help-seeking behavior among the patients and their caregivers, which ultimately result in delay in consultation for the psychiatric illness, resulting in longer duration of untreated psychiatric illness. People, despite of having psychiatric illness, they remain untreated for quite long time, and finally they consult. Some of the individual they consult for psychiatric illness. And still, there is, despite of so many advances, there is poor awareness of psychiatric illness, and people because with psychiatric illness they become frequently non-adherent to the treatment, and of course, a lot of negative attitude towards psychiatric treatment still prevails, which make the people non-adherent to treatment, and stigma is widely there in every part of the world. So during the course of psychiatric illness, if you see that uh, when a psychiatric illness develops, somebody who is not having any psychiatric illness, sometimes they develop some prodromal symptoms, then syndromal onset of psychiatric illness happens. And during the course of the illness, sometimes and during one point of time, patients with psychiatric illness, they consult for their psychiatric illness. And many of the patients, sometimes they end up in a state of treatment resistant state. So if you uh, talk about intervention, so in different phases, the focus of interventions are different. When somebody is not having psychiatric illness, do mental health intervention is required? Exactly, mental health intervention is required, but the aim of the mental health intervention is for health promotion, for ensuring the positive mental health. So it's more of a primordial prevention or primary prevention. As the prodromal symptoms start, sometimes we talk that somebody is having some of the subsyndromal symptoms, ultra high risk of psychosis, some psychotics, some um, fluctuating psychotic symptoms or fleeting psychotic symptoms are present, micropsychotic episodes are there. So those conditions, whether it need to be treated with any pharmacotherapy or any structured intervention, it is still a debatable topic, and most of the guidelines they recommend that it is important to be watchful and focus on the health promotion. If the patient develops syndromal symptoms, probably that individual requires a proper treatment, psychiatric treatment. So once the psychiatric illness starts, then focus is mostly diagnose as early as possible, treat as early as possible. So that is the focus of early intervention. If you treat early, the outcome is always better. Conventionally, people uh, usually takes a month, weeks to months for psychiatric consultation. It totally depends upon what type of psychiatric illness that person is having. Suppose somebody is having uh, rapid deterioration of the psychiatric symptoms, patient is having severe mental illness, maybe patient is having a good support in the family. Family members are quite aware of psychiatric symptoms and aware of the psychiatric services. Then probably they can reach the psychiatric service bit early. When there is stigma, unawareness, people don't know where to consult, then usually the treatment process get delayed. So duration of untreated psychosis, we usually talk in research that when the duration of untreated psychosis is very long, the outcome is also not good. So shorter the duration of untreated psychosis will have a better outcome. So usually since they reach the consultation forum after long pathway of care, after consulting multiple general care physicians, traditional healers, particularly in India, we see people consult a lot of traditional healers first, then subsequently primary care physician, then reaching to a psychiatrist. So with a long pathway of care. And when patient develops treatment resistance, in those conditions particularly, people require augmentation with some medications, with neuromodulation, with psychotherapy, or sometimes people require a combination of multiple treatment modalities. So over several decades, the focus is gradually shifting towards early diagnosis and treatment, irrespective of the illnesses. It was previously for non-communicable diseases, infective diseases. Now it is also very much applied to the psychiatric illnesses. The early you diagnosis, the early you treat, you can have a better outcome. Some evidences regarding early intervention in psychosis. Patrick McGarry is a leading prominent figure who conceptualized about early intervention in psychosis. It is a very evidence-based approach. A lot of research happened over past 2 decades. Uh, if we do early intervention, it is having a preventive role as well as promotive role as well as curative role. So it's having a definite upgrades over the conventional modality of treatment. Several evidences exist that how to do early intervention in psychosis. Before the onset of psychosis, if you identify an individual who is having ultra high risk of psychosis, how to do the intervention, what type of genetic manipulation can be done. Suppose somebody who developed psychosis or developing prodromal symptoms of psychosis, or there is a ultra high risk of psychosis in that individual, and can we do something in the intrauterine life? Can we prevent some uh, potential risk factors to facilitate uh, non-development of psychiatric symptoms? Can we arrest the development of psychiatric illness in an individual by doing any intervention? Then some other interventions can be done. Once somebody develops psychosis, immediately after developing psychosis, can we do something like, can we do some change in the psychosocial milieu of that individual that will facilitate the recovery from psychosis? So this type of interventions are usually discussed when we talk about early intervention in psychosis. So early intervention basically focuses on identifying different barriers for early detection of psychiatric illness. Several barriers that we have discussed, that unawareness, stigma, uh, negative attitude towards psychiatric illness, poor psychosocial support, unavailability of psychiatric facilities in particularly the low and middle income countries. All those barriers need to be uh, addressed properly. How to overcome those barriers, that need to be focused. Then we need to identify the early risk states. What are those early risk states which can say that this particular individual is going to develop psychiatric illness, particularly like um, use of cannabis with schizophrenia is a, or use of amphetamines with psychotic illnesses. So this is something very well established risk factor. So identifying those risk factors and addressing those risk factors can help you in early intervention. Then focused and specialized, more of a personalized intervention can also help. Particularly, we can prevent the adverse outcome due to the illness. So, early intervention focuses on early detection of illness, identifying those barriers that prevent the early detection and overcoming those barriers, providing personalized, specialized intervention, and ultimately all those interventions. The goal is to achieve early remission. The patient can resume the work as early as possible. There is better functioning, better quality of life, and the disability will be less. When we talk about any illness, irrespective whether it's psychiatric illness, whether it's medical illness, whether it's any type of lifestyle related disorder, the goal of treatment is same. That is, when we treat that condition, the focus becomes how to achieve the remission early, how to make the patient work, resume the work early, how to make the patient functional, how to make that individual uh, having a better quality of life, how to minimize the disability. So that is the focus of early intervention as well as focus of any modality of treatment. So early intervention exclusively focuses on making the patient better as early as possible. If you see the conventional treatment ladder, whenever somebody is presenting with some psychiatric illness, the consulting psychiatrist initiates the treatment. Depending upon the response, the dose is optimized. If there is no response after a adequate optimal dose of medication for an adequate period of time, then the clinician considers switching of the medication to another medication. Then, even after switching, if there is no response, then traditionally the clinicians consider augmentation by combining any other modality of treatment, maybe pharmacotherapy, maybe psychotherapy, maybe a neuromodulation. Even after augmentation, if there is a minimal response, then probably the clinician considers combination of treatments. So combination of different modalities of treatment together. So treatment augmentation is basically focusing on enhancing the therapeutic effect of the primary medication that is being used. Augmentation can be done through pharmacological strategies, psychological strategies, somatic treatment like electroconvulsive therapy, RTMS, TDCS can be used for augmentation. So conventionally, we move from treatment initiation to optimization to switching to augmentation, then combination of treatment. So treatment augmentation is considered late in the course of treatment, somewhere after the failure of optimization and switching. And clinicians usually consider treatment augmentation if the patient is a partial responder to treatment or a poor responder to treatment. Those individuals who respond well to treatment, optimization and switching, probably those individuals don't require augmentation and clinicians don't consider about treatment augmentation. But partial augmenters, responders and the poor responders, they are the potential candidates who actually require augmentation. So it's a emerging concept. Uh, Early augmentation is a new concept, relatively new concept. Over past 2 decades, people talk about early augmentation. The purpose of early augmentation is to introduce augmentation strategy early in the course of treatment to achieve the early remission. So this is the first documented evidence about early augmentation in psychiatry. So this was published in 1999, Journal of Clinical Psychiatry. So it's a case report. Basically, they used methylphenidate stimulant as an add-on to sertraline, and they compared it with another uh, individual with sertraline alone. So they found they published as a letter to editor. So it's a small pilot study. They found that those receiving add-on methylphenidate with sertraline, they respond better and there is an early reduction of the symptoms. So this is a pilot. Sorry, it's not a case report. It's a pilot study published as a letter to editor. So those who receive stimulant add-on with sertraline, which is introduced early in the course of treatment, they respond better, and they respond. There is a early reduction of the symptoms. So early augmentation is basically introduced somewhere early in the course of treatment, whereas early intervention. So sometimes it is confusing. People ask that how early intervention and early augmentation are different. Early intervention basically focuses on starting the treatment as early as possible once the psychiatric illness is diagnosed. Whereas early augmentation considering the augmentation strategy early in the course of treatment rather than waiting for the conventional process of optimizing, then switching, then considering augmentation. It can be added to the course of treatment early in the course. So we'll say that why there is early augmentation, why there is a need of early augmentation. We all know that Indian studies, they say that around 85% people, they don't, in spite of having psychiatric illness, they are not able to get psychiatric treatment. So treatment gap is somewhere around 85%. There is poor help seeking behavior. People are enrolled to the treatment program very late in the course of their illness. There is significant impairment in disability. Conventionally, when the treatment is initiated, conventional strategies followed, augmentation is introduced late in the course, particularly for the partial to non-responder of treatment. So it ultimately results in delay in reaching a remission, prolongation of the illness, prolongation of disability, impairment, and there is poor quality of life, and ultimately leading to increased cost of care. So if you consider augmentation early in the course of illness, early in the course of treatment, probably early remission can be achieved, probably the functioning will be better, probably the person can resume the work early, and the quality of life will be better. So maybe the cost of care will be less. So a research that is published in 2018, they considered early augmentation versus late augmentation, particularly antipsychotic treatment in patients with major depressive disorder. So antipsychotics agents are commonly used as augmenting agents in the treatment of resistant or difficult to treat depressive disorder. So risperidone, aripiprazole are commonly being used. So this study, they investigated the role of early augmentation with compared with late augmentation. They found that when you consider early augmentation, it is associated with early reduction of the symptoms, lower hospitalization rate, and ultimately leading to lower cost of care. So people think that if you start early augmentation, you are adding a treatment early in the course of treatment, there is a additional financial burden for the patient. Okay. So initially the financial burden may be high, but once the patient resumes the work, there is a better functioning and the low risk of hospitalization. So finally, the cost of care will be less. Ultimately, the cost of care treatment will be less. So the final outcome is it is a better effective modality of treatment with low cost of care. Interesting article published in 2013. So they use sertraline for the treatment depression in one group. In other group, they use sertraline with transcranial direct current stimulation. Interestingly, they found that those individuals who received a combined treatment of sertraline with transcranial direct current stimulation, they are having a better reduction of symptoms than those patients who are receiving sertraline alone. In this group, there are three arms. One arm is receiving sertraline and transcranial direct current stimulation. Second group is receiving sertraline alone. And third group is receiving TDCS neuromodulation modality alone for the treatment of depressive disorders. So those receiving combined treatment, they have a significant reduction of the depressive symptoms in compared to the sertraline group and TDCS group, which indicates that starting early augmentation may give better reduction of the symptoms, quick reduction of the symptoms. We also used similar strategy in our research over past few years. When you add neuromodulation facility as a augmenting facility with low dose of antidepressant, particularly uh, even you can treat the resistant depression more effectively. So resistant depression patients usually require in the due course of time, they require multiple combination of antidepressants, multiple augmentation strategies, electroconvulsive therapy, all those things. But if you start augmentation early, then probably those individuals may not require a higher dose of antidepressant, may not require a combination of therapy. So it may be useful in breaking the resistance. We have also used early augmentation strategy in the management of OCD. Very recently, I was just going through some of the existing research. Evidence supports that combination of psychotherapy with pharmacotherapy is superior to uh, these therapies alone. Like cognitive behavior therapy is one of the commonly used psychotherapy modality used for treatment of OCD. When you are combining CBT with pharmacotherapy, it is superior to CBT alone and pharmacotherapy alone, particularly in the management of depression, uh, OCD, and panic disorder. So, spectrum of disorders, anxiety disorder, OCD, and depression, combining psychotherapy gives a additional benefit. And psychotherapy is something that is introduced very early in the course of treatment. Clinicians usually suggest pharmacotherapy as well as simultaneously they start psychotherapy. So psychotherapy, and it is seen that a combination of therapy is more effective than individual therapies. It clearly indicates that psychotherapy, when introduced early in the course as an augmentation strategy, may give better results. So if psychotherapy gives better results as an augmentation strategy, then why not neuromodulation? Then why not a pharmacotherapy add-on? Early in the course will give a better result. So, similar kind of article published in Lancet that says that a combination of CBT pharmacotherapy is superior to these therapies alone, particularly in cases of moderate to severe OCDs at least. Uh, we did a study in 2022 that is published in CNS Spectrum. So we added repetitive transcranial magnetic stimulation (RTMS) as a add-on strategy, as an early augmentation strategy to the ongoing pharmacotherapy in patients with OCD. So what we did, this is a study with a relatively smaller sample. So a group of patients, they received escitalopram, a dose range of 10 to 20 milligram per day, and active TMS. Other group received 10 to 20 same dose of escitalopram with SAM TMS. So patient received 1 hertz uh, frequency, 80 pulses in a train, total of 1600 pulses per session, one session daily for 20 days over a period of 4 weeks. Supplementary motor area was targeted. It was a well accepted modality of treatment. None of the patients they reported any major side effect, and there was significant improvement of the symptoms, particularly OCD symptoms, in that group who received active TMS with pharmacotherapy. So it indicates that if active neuromodulation technique like TMS or TDCS can be added early in the course of treatment, that can lead to early reduction of the symptoms. Similar kind of evidences also exist that people tried with adding lamotrigine and aripiprazole as a augmentation strategy to clomipramine in management of severe OCD as an early augmentation strategy, and they found significant reduction of the symptoms. And this is a case study. The reason for adding lamotrigine is in this case, patient was given a relatively high dose of clomipramine, up to 200 milligram of clomipramine, and in that dose, the patient developed seizure. It is known that clomipramine reduces the seizure threshold, so patient developed seizure. So they added lamotrigine for seizure prophylaxis, as well as lamotrigine is having some antiglutamatergic properties, and which is known to cause having an augmenting effect, particularly in OCD. That's why memantine is commonly used as an augmenting strategy in OCD. So additionally, they use aripiprazole. So aripiprazole lamotrigine combination is a safe and effective combination as early augmentation strategy in management of OCD. Similarly, in another case series of adolescent population, 6 adolescents, they used aripiprazole early augmentation with ongoing serotonergic medication SSRI, and they found significant reduction of the OCD symptom, particularly pediatric OCD symptoms. So aripiprazole can be added as an early augmentation strategy. Is it safe in the adolescent population as well? Recently, we conducted a series of RCTs to check the efficacy of early augmentation strategy. This is one of the strategy uh, where we used transcranial direct current stimulation as an early augmentation strategy in the management of depression. Uh, the findings suggest that when you use TDCS as a augmentation strategy targeting the bifrontal area, uh, stimulating the left dorsolateral prefrontal cortex by placement of anode and inhibiting the right DLPFC by placement of cathode. Over a period of 2 weeks, we delivered 10 sessions. The patients who received active TDCS, there is a significant reduction of the depression severity as manifested by the HAM-D scores. So early augmentation using TDCS result in early reduction of the symptoms. Similarly, in another study, we used TDCS as an early augmentation strategy in adolescent OCD patients. So 16 patients were enrolled in the study, and those individuals who are receiving uh, active TDCS as an augmentation strategy to the ongoing pharmacotherapy, there is a significant reduction of OC symptoms in the first 2 weeks. Though the effect is not sustained, so there is a early reduction of the symptoms that may happen. We also did early augmentation by using electroconvulsive therapy in patients with schizophrenia. That resulted in early reduction of the symptoms, and patient was managed with a relatively lower dose of antipsychotic. So neuromodulation, psychotherapy has been significantly used as an early augmentation strategy. It has been recommended early in the course of treatment. However, neuromodulation is something that is being introduced late in the course of treatment once the case becomes refractory to treatment or difficult to treatment. So neuromodulation can also be introduced early in the course of treatment. That will help definitely in reducing the symptoms early. So understanding those things, we developed a model. So early augmentation is not made for everyone. We need to identify different risk factors, particularly different risk factors for who are those individuals who are going to be partial responder or non-responder. Clinical history can give some of the clues, like if you think of obsessive compulsive disorder, if somebody is having multiple obsessions, that individual is likely to have partial to non-response than single obsession. Suppose somebody is having early onset OCD. Suppose somebody is having OCD with obsessions which are more of hoarding type of content, symmetry related things are there, aggressive sexual contents are there, or magical thinking is there. If this type of obsessions are there, then those type of obsessions are relatively refractory to treatment, and the patient may develop partial to non-response. Suppose somebody is having a poor insight to the illness, OCD, that is a poor prognostic indicator. So we need to identify those poor prognostic indicators from the clinical history and mental status examination of the patient. Sometimes the neuroimaging can give a idea about whether the individual is going to have a good response or poor response to treatment. Particularly when you talk about psychosis, suppose somebody is having ventricular volume is increased, cortical atrophy is significant, those individuals may not be good responder to treatment. They may respond partially, or they may not respond significantly to the treatment. Other biological markers, genetic markers, different difficult psychosocial circumstances can also predict the outcome. So if somebody is having multiple risk factors, then one should consider about early augmentation. If risk factors are minimum and good prognostic factors are met, are there, then probably conventional treatment may be enough for that patient. That patient may not require early augmentation. There are some few ongoing projects now we are doing. Here we are using TDCS as an early augmentation strategy in the management of OCD. The patients were divided into two groups. One group is receiving fluoxetine plus TDCS. Other group is receiving fluoxetine with SAM TDCS. 10 sessions of TDCS are delivered over 2 weeks and their effect are monitored immediately following intervention, then 4 weeks and 6 weeks. The interim analysis of this is an ongoing project, and the interim analysis of the data, it suggests that those who are receiving active TDCS, there is a better reduction of the symptoms than those who are receiving SAM TDCS. So this is the trend we are getting. A similar kind of study we are doing for adolescent depression using TDCS as an early augmentation modality. Again, patients were receiving sertraline as antidepressant treatment and TDCS as an add-on treatment early in the course of illness. So the trend is again similar. Those who are receiving active TDCS, they are having better reduction of symptoms than those who are receiving SAM TDCS. So now the question is, when will say augmentation to be early? So there is no consensus about it. The study that is conducted by Yermilov in 2018, so they indicate that suppose you introduce the augmentation within 0 to 6 months of treatment initiation in the management of depression particularly, and they call it early augmentation. So it should be more of a disorder specific, like uh, 0 to 6 month time can be for depression, but for schizophrenia it may be different, for bipolar it may be different, for uh, OCD it may be different. So it need to be specified according to the illness. So who are those individuals who may need early augmentation? Particularly person with psychiatric illness with a lot of poor prognostic factors, multiple risk factors, who is having past history of poor response to adequate trial of antipsychotic, psychotropic medications. There is family history of poor response to treatment. Probably these individuals are potential candidates for early augmentation. Sometimes the genetic markers, neuroimaging markers can also guide the clinician for identifying potential candidates for early augmentation. Expected benefits from early augmentation, that we can get early remission of the symptoms. There may be better functioning, less disability, better quality of life, employment opportunities becomes high, stigma will reduce, caregiver burden will reduce, cost of care will reduce. Ultimately, if these changes happen, this may change the attitude towards psychiatry by the patient and their caregivers. Even the clinicians, even the psychiatric students who are witnessing the benefits, their attitude towards psychiatry will definitely change. The dilemma related to early augmentation in psychiatric disorders, it is definitely going to add one modality of treatment additionally in the course of treatment, may result in polypharmacy. An additional treatment also increases the risk of additional side effect. The initial cost of therapy may be a bit high. There may be usually many psychiatric patients. They are quite reluctant for taking psychiatric treatment. So, if you are adding another modality of treatment additionally, then reluctance may be further more. So, these are the challenges. I'll say there are still there are limited evidences. We need to have more research, more number of randomized controlled trials. It's a very under discussed area. We need to identify who are those potential candidates for early augmentation. Early augmentation cannot be routinely recommended for all the individuals, but definitely for those individuals who are having a lot of poor prognostic factors. We need to explore about different treatment options like neuromodulation, psychotherapy, pharmacotherapy, what type of early augmentation strategy need to be considered. Sometimes use of artificial intelligence may help in identifying the potential candidates suitable for early augmentation. Using a different, we can develop an algorithm for identifying who are those poor responders, and they can be enrolled for early augmentation. So I will conclude by saying that early augmentation is not recommended or may not be required for all the patients with psychiatric illness, but those who are having lot of poor prognostic factors are probably the probable suitable candidates for early augmentation. Even if the early cost of care is high, but the outcome is good and the functioning becomes better, early resumption of work happens. So ultimately it will compensate for the expected beneficial outcomes. So there is need of more research, more number of RCTs need to be done to gather evidences that how early augmentation can be recommended for clinical practice. Briefly, I'll say that conventional augmentation will take you slowly towards the target. Early augmentation will take you quickly towards the target, though the initial cost is high. Here I will stop. I will be happy to answer if you have any queries. Thank you so much.
Okay, yeah, well, thanks for this very interesting talk, and I think it's a clinically very, very relevant issue. And I just don't know when I'm here taking over. Can you hear me? Yeah.
Yeah.
Right. Okay. I don't know. So the question is very much, what is, so I don't understand sometimes, you know, what you shown initial, or sometimes have been shown that a combination is better than the initial one, is that one therapy. So the question is the effect from the second, let's say, I don't know, I'm confused about what would you recommend, but let's say it's that way. You have two therapeutic inputs, and from these two therapeutic inputs, you could say augmentation is just one works or the other one works. So, or is it the augmentation? So what is a specific effect of augmentation, let's say, in medication? You know, what you produce here is the fact that two medications or two interventions work better than one. So that has been shown in psychotherapy. This has been shown in other things. But the question is it just the fact that some people respond to one, some respond to the others, and then the number of people who respond in together is more than the individual parts? However, what would you say? So how would you disentangle this from this saying, okay, it's additional effects from the fact that some people respond to one or the other, or that they respond only to a combination of something?
Exactly. This is some area that is not evaluated thoroughly. It's very difficult at this point of time to say that. Suppose if you consider the pharmacological augmentation strategies in OCD itself, it can be done with risperidone, it can be done with aripiprazole, antipsychotics, it can be done with buspirone, it can be done with memantine, it can be done with ondansetron. So what augmentation strategy need to be considered early in the course? One should consider risperidone or aripiprazole or topiramate or lamotrigine or buspirone. So how to decide that? So that has not been systematically studied. Maybe after doing more research, we will be able to answer these questions. Like we can try with different phenomenologies and different severities. Like a group started with serotonergic medication with risperidone, serotonergic medication with aripiprazole, serotonergic medication with buspirone. Then finally, doing a network analysis, network meta-analysis, which combination acts well, that will answer to this question. So for that, we need to have more number of RCTs. So it's too early to comment which combination will be better for the individual to start with, rather than monotherapy.
Okay, before I invite other people to ask questions, you know, and not to be too shy, I would also ask if you can, you said, there should be some differences between timing. One of the problems we have in clinical work is that people usually just want one intervention and don't want to take too much. So the question is, if, let's say it that way, if you always start with 2 interventions, or then you say maybe only one helps and you don't need the other. So very often you have the risk of doing too much. And that might be a problem, especially when you look at the costs of medication. So the question is, what is the timing? What's the best timing for these? You mentioned it very shortly. What's the best timing for these different disorders? OCD is something which is, I think something where you have a very long timing anyway. So, and whatever mania, possibly if you start a therapy or augmentation after 6 months, you possibly the diagnosis is gone by this time. So I think there should be some recommendations, very different. So can you comment on that or give some better data?
Yeah, in our 5 to 6 studies that we have conducted, we introduced augmentation early in the course of treatment. That is within 1 week of starting the main treatment. Like for the depression, we have started antidepressant treatment, that is escitalopram, and augmentation neuromodulation has been started within 1 week of initiation of escitalopram. Similarly, in the treatment of OCD, within 1 week of start of fluoxetine, we started the neuromodulation. So that give us this type of result. So whatever the existences that report, that studies that I referred to, people have introduced the augmentation ranging from 1 month to 3 months from the initiation of point of initiation of treatment. Suppose they have started clomipramine for the treatment of OCD. Within 1 to 3 months of initiation of clomipramine, they have introduced the augmenting agent. So they called it early augmentation. Yeah. So this is a dilemma, and to say it's early augmentation, there is no clear consensus about it. So we need to have more number of evidences that at what point of time one should introduce augmentation, so that will cause early reduction of the symptoms. So we need to have more studies to answer this question.
Yeah, Dr. Sharma, are you just go ahead with your question. Dr. Sharma, you have to unmute if you want to say something. You just have to unmute her, so I don't know. All right, I don't know what happened. Okay, I think you wanted to dash off, and I'm very grateful for your talk. And
thank you.
If there's no other question from Dr. Sharma, I don't know what's going on. Then I'll let you go, and hope you have a nice family time. And we give it a couple of minutes to sort out the next speaker, because I have to present the slides. And yeah, is there anything you'd like to mention, or anybody? David, have you got any questions to the speaker? No. You have to unmute yourself. There's a microphone somewhere on the picture, and you can unmute.
Yes, you can hear me now.
Oh, great! Yeah.
Yeah. Congratulations. I think that was a wonderful presentation. Will this presentation be made available to us, to people who are on this panel?
Yeah, if you want to, no problem.
Please send it over to me. I'll get it on Tuesday, because Monday is a public holiday.
All right, no problem.
Thank you.
Okay. Right. So I don't know. So now I'm speaking, but I'm not coming up here, so I don't know what's happening here. Right. Okay. So give me a second. So Sujit, thanks a lot, and we have a chat next week, and see how it goes. And here, have a nice day. And I would like to just more or less wait a couple of minutes, because people usually come up with within the hour. Yeah. So we relaxate.
Thank
Thanks
you
a
so
lot.
much.
Okay, and I try to get up the slides here. Is that okay?